I can see some really tired, fatigued faces. So I'm going to try and make this as interesting as possible. I have also been in your shoes for a long, long time. I was a Wellcome Trust Fellow from 2000 right up until 2 years ago when I retired from my Principal Research Fellowship. And what I'm going to do today is take you through actually 2 case studies of my own research and hope that as I do so, some key messages, and we've heard some of those key messages already in the last panel, might serve to inspire you. I'm actually primarily a clinician, but I hope what you'll see is that in everything we do in health, it's really so very important to look beyond our narrow discipline, and I think some of the ideas, some of the work that I've done will hopefully illustrate that through my research. Now, my subject is on mental health, and what I hope to do is to say a little bit about why we need to have a radically different approach to mental health science and why that science must be fundamentally integrative, and you'll get a good example of that in my talk. So I want to start by first explaining why we need a completely different approach. This slide comes from the Global Burden of Disease report. This is just to introduce you, this is a way of measuring the overall burden of all health conditions and then looking at which different health conditions account for the burden of disease. And in this slide, what you can see is the burden of mental disorders as part of a pie chart of the total burden of all health conditions in different countries of the world, organized according to how wealthy they are in a socioeconomic sense. And you can see from 1991 to 2016, no matter which country in the world you live in, the burden, relative burden of mental health conditions has increased by 50%. You also see that as countries become richer, as you go up this particular, this y-axis, that the relative burden increases. And the reason primarily for that is driven by 2 factors. The first is the population transition. You have more and more people moving out of childhood into adolescence, which is when most mental health problems begin. And the second, of course, is that most countries, as they become more developed, get better at controlling infectious diseases. And so that's why you get a relative increase in the burden of mental health problems. A second very important reason why we have a crisis of mental health is that we've only very recently begun to recognize that mental health problems are not what clinicians see in their psychiatric clinics, which is usually people in their 30s. But in fact, mental health problems begin before you even reach your 20s. And this is why most mental health problems emerge during the phase of adolescence between the ages of 10 and 25. And during these years of life, mental health problems account for the largest burden of suffering. However, most adolescents will never come to a clinic, which is why you get the rather odd observation that most adults who are coming to mental health, to psychiatric clinics are in their 30s, but in fact they've had mental health problems that began 15 or 20 years earlier in their life. But when you look at it from a life course perspective, most mental health problems begin much earlier in life. Another very important factor, and Shivani touched on this, there's often been this notion that poor people and poor countries, therefore, do not have a concern with non-communicable diseases. In fact, nothing could be further than the truth when it comes to mental health problems. This slide comes from the National Mental Health Survey, which was the largest ever survey conducted in India by the Ministry of Health, published a few years ago. 33,000 adults took part in this survey. And what you can see here is the prevalence of depression, the most common mental health problem, according to income quintiles. And what this slide tells you very clearly is that the richer you are in India, the lower the prevalence of depression. Or put another way, that depression is associated with poverty, just like, in fact, many other health conditions that are prioritized in India. We also have a very good mechanistic understanding of why poverty and poor mental health are interrelated. For a whole range of mental health conditions, there are very strong associations between disadvantage and poor mental health, from developmental disabilities to substance use. Here you see just one illustration for depression. This was published in Science a few years ago, and it's a very detailed analysis of the mechanisms through which poverty and depression are related. And what we really conclude from this particular infographic is that this is a bi-directional relationship. When you're poor, you're more likely to slide into depression because of a range of different mechanisms that you see here. And when you have a depression or an anxiety condition, you're more likely to slide into poverty, setting up, again, you see a range of different mechanisms here, and this, of course, sets up a vicious cycle. So, in summary, this is why thinking about mental health problems is critically important for India and indeed for global health. Now, very often when we think about global health, the first thing we think about is that these are problems of poor people in poor countries, and rich people in rich countries have figured it out. Is that the case for mental health problems? It is the case actually for many other somatic conditions, for example, many forms of cancer. Is that the case for mental health problems? Well, let me address the US, a country which I've become extremely familiar with since 2017 when I moved from India to join Harvard Medical School, and have had an opportunity to interact very closely with policy, practice, and research in that country. Now, you think the US should have fixed their mental health crisis. And there's a good reason why you should think that. The US has more mental health professionals per capita than any other country in the world. You'll see here population size of different countries, China and India is out there. And on the y-axis, you see the per capita density of psychiatrists. And you can see, whoa, look at them here. 35,000 psychiatrists, making it the most well-resourced country in the world when it comes to mental health professionals. And this is just psychiatrists. If you had to add psychologists and psychiatric nurses and so on, the US is off the charts. Not only does the US have more mental health human resources than any other country in the world, it also spends more on mental health care than any other health condition. Most people don't realize this. We often think of, cancer care and diabetes care, etc. Actually, mental health care is the single most costly condition in the US. Keep this in mind, because if we had to follow the US model, we would gradually bankrupt an already very under-resourced healthcare system in most parts of the world. But let's assume all this spending should achieve a decent result. Not at all. It turns out that all this spending has had zero impact on the actual burden of any mental health condition in the US. This slide shows you the prevalence of depression, and I'll show you a little bit later, the prevalence of some other non-communicable diseases to contrast what we see with depression. Here's the prevalence of depression across these 10 years of observation, totally static. In fact, if anything, you will see a gradual incline. Actually, this is not an insignificant incline in 18 to 25-year-old people from between the ages of 2008 and 2015. This is in spite of all the doctors, psychiatrists, and dollars spent. But if prevalence is a somewhat intangible metric of burden of disease, let's consider mortality. This is perhaps the most shocking of all. Over the last 20 years, mortality due to mental health and substance use-related conditions has skyrocketed in the US. In fact, in the US today, this is the only OECD country in which life expectancy has actually started falling. That is the most amazing fact. Life expectancy is actually falling, and the decline is entirely driven by mental health related conditions, primarily suicide and substance use problems. In spite of all the money spent, more people with serious mental illness in the US currently call prison their home rather than any form of care institution. Now, of course, the US is a very broken healthcare system, but surely one should step back and ask the question, where has science really gone in trying to fix this crisis in the world's richest country? If I had to show you the per capita dollars spent on research, just like the per capita density of mental health professionals, you'll see the US is way off the charts compared to every other country in the world. In fact, my dear friend Tom Insel, who was the director of the NIMH, the world's largest mental health research funder, I've quoted directly from his recent book. The US spent more than $20 billion during his tenure of just about 10 years on mental health research, and during those years, every single metric concerned with mental health only got worse. This, in my mind, is a real problem. Because if science was supposed to solve health problems, then clearly what we're doing in mental health science is completely useless. It hasn't led to any new discovery that has helped us understand either the nature of any mental health condition, nor has it actually led to any new therapeutic intervention, nor has it led to any new target for prevention. Pretty depressing stuff, and I'm not talking about depression as a mental illness here. Now, over the last decade or so, many people around the world have begun to interrogate this. It isn't the question that science isn't answering the right question. The problem is, are we actually doing the right kind of science? A few years ago, Richard Horton at the Lancet asked me to lead a commission to actually interrogate this issue. What is going wrong here? And we produced this commission in 2018, and more recently, in fact, in press, we have another paper in the Lancet that is examining or trying to understand not only what's wrong, but also try to identify examples of what might point to a different way of thinking about our brain, what shapes mental health, and how we can prevent and care for mental health problems. In a summary, why have all countries failed to address mental health needs equitably? I and my colleagues have come to the conclusion it's because we've got the clinical paradigm completely wrong. We have organized our entire scientific establishment around diagnostic categories that were invented. Yes, the truth is that is the correct word. We invented these diagnostic categories in the 1970s based on clinical phenotypes that were seen in the clinics of psychiatrists working in Britain and the US, and assumed and hoped, for good reason I have to say, that in time we would discover what the mechanisms and the biological bases of these conditions were. As I said, 60 or 70 years of investment behind those clinical or diagnostic phenotypes has led us nowhere. But what it's done is, it's created a false premise of privileging biological mechanisms as the primary focus of research. It's premised treatment over prevention, unlike almost every other branch of medicine. It's premised specialist care over any other form of care for those who are struggling with their mental health. And it's focused on clinical phenomena, which are the focus of what psychiatrists are concerned with. Disclosure, I am a psychiatrist, rather than what actually matters to people who are struggling with mental health. Now, about 15 years ago, Tom Insel invited me on behalf of the NIMH to begin to actually understand whether there was a different research agenda, a different science agenda that needed to be pursued by the world's science funding bodies in order to actually circumvent this reliance on diagnostic categories. I chaired the Grand Challenges in Global Mental Health Initiative. We published our findings in Nature. This is in 2011. Essentially, what we put together was a large panel, nearly 400 scientists across all the different disciplines that are concerned with brain health. We put together also a group of policymakers, practitioners, people with a lived experience, and simply asked them, what are the key research paradigms that we need to adopt if we are going to shift the burden of mental health suffering in the world today? Because clearly the paradigm we followed for the last 60 years hasn't really produced the goods that we had hoped it would. And you know, we were contrasting with other branches like oncology. I mean, oncology, when I was a medical student, if you had cancer, it was, my goodness, this is so sad. Today, if you got cancer, there's 1,000 new ways of thinking about how you can treat these conditions. Not for a single mental health condition have we got any real radical advance to the things we've known for 50 years. The Grand Challenges of Global Mental Health led to a range of different kinds of research paradigms, amongst which, of course, at the heart of which were, let's abandon this narrow binary focus on diagnostic categories. Let's reimagine how we can, in fact, describe the phenotype of mental health problems, and so on and so forth. I'll recommend you look at this paper to see those, to understand a little better what those research questions were. I want to take you now through to two different case studies of research that I myself have led in India to illustrate to you how those different paradigms can actually lend potentially, hopefully, to transformative understandings of what shapes our mental health and offers new ways of thinking about prevention, but also how we can care for mental health problems in any resource context. And in both those paradigms, what I really intend to show is the need to step outside our disciplinary boundaries, our disciplinary silos, if we're ever going to really get to grips with the crisis facing the world. So the first case study is my program that sought to reimagine how we can care for depression, by far and away the most common mental health problem in the world, in a scalable way in low resource settings like we find in India. And the second case study is how we can detect disrupted cognitive development in early life, and you'll see why that's important to mental health a little later. So let's start with the first case study. Why is depression important? As I already mentioned, it's the most common mental health condition. It's the one that's associated profoundly with social disadvantage. It's also the one that's associated most profoundly with premature mortality, both through suicide. I don't know how many of you know that suicide is the #1 cause of death in young Indians. It's been the #1 cause of death in young Indians since 2000. But does anyone really talk about suicide through the lens of public health? No, I don't think we really do. Nevertheless, that is a fact. So depression is very important, not just in India, but globally. Now, we do have effective treatments, but those treatments do not target our so-called biological mechanisms that antidepressant drugs supposedly target. Actually, we have no idea how antidepressant drugs work. But there are treatments that have been around for 50 to 60 years that have been clearly designed around behavioral and cognitive mechanisms that owe their origins to science that is 100 years old. Behavioral science is more than 100 years old. Many of you have heard of Pavlov, for example. There has been a profound, rich, and deep science of behaviorism and cognitive science, which led to the design of psychological treatments, which, of course, almost no one receives. Now, there are many important reasons why nobody receives these treatments. One of them, which I think is a really important determinant of what actually shapes our healthcare system, you can guess what it is. There is no pharmaceutical company that is backing psychological treatments. And therefore, there is really no commercial incentive in the most effective intervention for depression to be made available to anyone in this country. There are also, of course, demand-side barriers. Let's be quite honest, people in our country do not really accept psychiatric diagnoses. And therefore, what we really do need to do is to not use diagnostic systems that are alien to people in India, but instead derive much more community-led ways of describing their mental distress so that people are more willing to seek care, but importantly, that care should be made available not in psychiatric settings, but in routine primary care. So the research challenge that I set out with about 15 years ago was the design of a scalable psychological treatment for depression that addressed both the supply side barriers, that is to say, we have no mental health professionals in India, but also demand side barriers, that is to say, we live in a country where most people would not accept that depression is a psychiatric diagnosis. This had to be delivered in routine care by available human resources, which is to say, people with no prior training in mental health, and it had to be cost effective. I've been very fortunate. The Wellcome Trust has been, one of the most risk-taking and innovative funders that I have ever had the privilege of being funded by. And as I mentioned to you, I've been funded by the Wellcome Trust from 1995 right up until 2020. And one of my senior research fellowships allowed me to launch this program to define a methodology that could address supply and demand side barriers, to design brief psychological treatments for populations such as we see in India, and then to conduct trials to evaluate their effectiveness. I set out with a very interdisciplinary team of economists, cognitive and psychological scientists, trialists, and of course people like myself, clinical scientists. And together we, first of all, said we needed to start with a blank slate. Rather than try to adapt methods that were really going to be impossible to scale up in India, by just simply taking something that had been developed in the West. We needed to actually build a house from the ground up. We needed to ask, and I use the metaphor of building a house here, what is the architecture of a novel treatment? Like in a house, what are the different rooms? And how should these rooms be organized in a way that is actually going to be acceptable as well as feasible for building in the Indian context? Now, I'm not going to take you through this slide. It just shows you a very complex design process that took us about 3 years to work our way through. We were, in fact, designing 2 completely different treatments, one for drinking problems, another one of those conditions that in India we tend to really see through a moral prism rather than a health prism. But I'm not going to talk of that today. And as I said, it's a complex set of methods, including reviewing the literature, qualitative work with people with depression in the country to find out how they deal with their symptoms, synthesizing that, working then with treatment design experts. I would really strongly recommend you also to be thinking from design perspectives. This is a particular methodology that you'll find engineers use a lot in their work. And then doing much more clinical research of testing this intervention with people with depression, and then finally arriving at a treatment that you could then test in a trial. What we resulted then with is a 6-session treatment. This would have been one of the shortest treatments for depression when we first published it in the Lancet in 2017. This is based on a very specific mechanism called behavioral activation. Again, for those of you interested, there's a lot more literature out there that I can point you to. But most importantly, we designed it so that it could be delivered by a layperson. Any one of you, whoever's not a mental health professional, I assume, which is probably most of you, could in fact be actually trained to deliver this treatment in about a week. And then we evaluated it with a large randomized controlled trial with nearly 500 individuals with severe depression, not mild to moderate. These were people with the most severe form of depression, which in Britain, for example, or the US, would almost certainly been on medication and possibly more in 10 primary health centers. I want to just acknowledge that almost all the work I'm going to be sharing with you today has actually been implemented by a non-governmental organization that's headquartered in Goa, but now has major centers also in New Delhi and in Bhopal. At the time, I worked at the London School of Hygiene and Tropical Medicine. Now, what this shows you is the 12-month clinical trajectories of the patients who were treated with depression. This is the group that received the Healthy Activity Program, the 6-session treatment, and this is the group that received enhanced usual care. So the care the control arm got was way more than what people normally get because, for ethical reasons, we shared the screening data with the primary care doctors. We trained them in the use of WHO guidelines for depression care. We gave every patient who was in the trial a lot of information about their condition. So this was a ton more than what people typically get in routine primary care. And I think the key figure to see are the red boxes here. What that tells you is that 80% of people who received this treatment, these are people with severe depression, showed some response over the 1-year period, whereas in comparison, only 50% of people in the control arm did. This is a pretty large difference for effectiveness. But what was really fascinating was that a few years ago, the economist Abhijit Banerjee, a colleague and a friend in the Boston community, approached me and said, his program, he's a behavioral economist, a development economist, was very interested to look at the impact of the treatments for mental health problems. Actually, his primary interest was, is there a relationship between poor mental health and poor decision making in terms of financial decision making? This is a very big field in economics these days. And he wanted to know, therefore, the counterfactual, that if you treated people with depression, could you find economic benefits in those individuals? And he asked me, Vikram, can we actually follow up your cohorts of people with depression. We already had preliminary economic data in the 12 months that I had funding to follow up these patients. And we'd already found that those who received the treatment, it was a cost-saving intervention because these individuals who got back to work, they spent less on healthcare, etc. But I hadn't had the idea of following these individuals up anymore. So he funded a follow-up 5 years after the trial, and 5 years after a 6-session intervention that in totality was about 2.5 hours of therapy time by a layperson, his team still found, this was his team, not my team, still found statistically significant differences in remission rates in patients with severe depression. So in some ways, when you step back and think about how a brief treatment deliverable by anyone in the community, but eschewing psychiatric diagnostic categories, could lead to these long-term effects, you can begin to see how important it is to start thinking beyond the narrow. Now, a single study does not make science. I'm sure all of you know that. Replications are probably the single most important thing in science, and I've been thrilled to see how often this 6-session treatment's not only been replicated, but in different countries with different populations, and most recently, it's now been adapted for use in the US and Canada, which in my mind must be a pretty rare instance for a treatment or a program of intervention developed in India, or indeed any developing country, being adopted in the world's richest country. The work that I describe here is not just my work. There's in fact now more than 100 randomized controlled trials, thanks to the grand challenges in global mental health. More than $1 billion of new money has gone into funding this completely different way of thinking about mental health research. And this is redefining care by redefining what comprises interventions. These are mechanistically informed interventions rather than the serendipitous kind of use of drugs that have no real mechanistic basis. Actually designing interventions based on cognitive or behavioral science in this instance, but also interventions based on social sciences. These are delivered typically where people are, not where the clinicians are, delivered by people who are available in the community, and delivered often as part of an extension of the healthcare system. The evidence is not being ignored. The evidence is not even just 15 years old, but it is already beginning to plow itself into policy documents. Here I show you examples of policy documents that has incorporated, embraced this evidence. The top 3 are coming from the World Health Organization, and the bottom 2, this one is the World Bank, and this is India's national mental health policy. Very relevant for all of you here. I was invited by the then Health Secretary to serve on the drafting committee. Our initial trials were just being published at that time, and Mr. Keshav Desiraju, who's no more with us, was very excited about the idea that we could use frontline workers in India to do something that actually we never thought was plausible, and thanks very much to that science. So the next step for me was, I had all these papers in these journals, but the policy documents were saying this is something we had to scale up. But the question next was, how do you scale this up? How do you train 1 million ashas that need to be trained in these brief interventions? We couldn't adopt the methods that we use in trials. Because in trials, what we do is we try to maintain fidelity to such a high extent that we actually have experts coming in, running workshops, very intensive monitoring of supervision, etc., for good reason, because we want to make sure that we find a good result of the intervention. But those methods, they're not scalable. So what I started exploring was working with engineers, with digital scientists, with people who are involved with education. How can we scale up these brief behavioral interventions in the real world? Just before the pandemic, by good fortune I say just before the pandemic, because just before the pandemic, people were very skeptical that you could train others using digital technologies. Today you can run entire master's programs in Harvard entirely on the web. But at that time, people said, no, it's not going to work. You can't be training people remotely using smartphones. Nonetheless, it seemed like there was no other option at the time. So we launched Empower as a joint program of Harvard and Sangat in India. And we started deploying technology in 4 different ways. Something that's pretty straightforward, competency-based curricula that could be delivered on any learning management system in the hands of a frontline worker's phone. But beyond that, using remote platforms for assessing competencies, using, again, remotely delivered skills assessments. We've designed a bespoke app with the Boston-based tech company called Dimagi, which also has a very big presence in India. Shah will know Dimagi well from prior collaborations we've had with them. But they worked with us to design apps for supporting frontline workers to supervise each other. And then data science-driven evaluation of the digital data that arises so that we can now measure, not only measure the quality of care, but we can start examining in the process of care which metrics of quality predict patient outcomes, and then begin to use those in data science-driven ways to improve the effectiveness of the overall delivery system. I'm going to finish the case study by telling you about where we are right now. As I speak, this program is being scaled up in partnership with the Ministry of Health in the state of Madhya Pradesh. And the first of 2,000 ASHAs, this is not a research program anymore, but a real-world delivery program, are in fact delivering the 6-session treatment to people with depression in their own communities. Of course, we're harvesting data on the Empower platform that allows us to look at the implementation metrics. But the most exciting thing is that this entire intervention program has been exported to the United States, where today, with a number of other institutions in the US, we have taken a 6-session treatment that was developed and tested in Goa to the US. Our first place of implementation is in Texas, where, thanks to a prize that we received right in the middle of the pandemic, we are now bringing an Indian innovation to the US and delivering it through a digital platform for training, supervision, and quality assurance. I want to then, in the interest of time, just quickly skip on to the second case study, which illustrates a very different kind of use of technology for a very different purpose in the mental health space. I don't know if Beena Koshi is here, but essentially, this is very much along the lines of the work that she described in her presentation. And that's to do with early child development. Now, why is that important to mental health? You don't usually hear the words early child development and mental health in the same bracket. I'll tell you why in a moment. But first, let us acknowledge that in no branch of medicine have we been able to reduce the burden of a health problem by treatment alone. In no branch of medicine. Here, you will see a very interesting slide that shows you the burden of disease of ischemic heart disease in the red line here, and of depression in the blue line here, over the last 30-odd years. The message is clear, right? Over the last 30-odd years, we have seen a dramatic, absolutely dramatic reduction in cardiovascular mortality of all kinds. For strokes, for myocardial infarction, all vascular mortality has gone down. Depression, as you've seen already earlier, it's not just a US phenomenon. Depression is flatlined. Schizophrenia is flatlined. You look at almost any mental health condition, no change over the last 30 years. Now, many cardiologists would like to think that this reduction is because of the heroic efforts in introducing stents and doing bypass surgeries. Nothing could be further than the truth. Most of this decline, some of it is, but the vast majority of this decline has been driven by prevention. And that, of course, to a large chunk of that is, of course, through tobacco cessation policies, and of course, there are some other things as well. This points, of course, the point I'm trying to make here is that prevention is what really drives the reduction in the burden of a health condition. Now, in the mental health space, we've struggled with this. We really struggle because, do we have a target for prevention? Well, we do. This grumpy chap that you see here, anyone who is a mental health professional will recognize him. He's a very iconic figure, actually, and I think derided, but for the wrong reason. This is, of course, the Austrian neurologist Sigmund Freud. Sigmund Freud, more than 100 years ago, was sitting in his clinic in Vienna examining various individuals who came to him with very strange somatic symptoms that he later went on to diagnose as hysteria. he couldn't understand the cause of these conditions. People came with seizures, they had all kinds of strange neurological symptoms, but they had no neurological lesions. What he then did was looked at their life stories, and he discovered that almost all of these individuals had very traumatized early lives during their childhoods. There seemed to be some mysterious connection between what was happening to these individuals when they were very young and the appearance of these strange symptoms in their 20s. Now, at that time, we knew even less about the brain than we know now. In fact, we knew very little about the brain then. So he invented a causal theory on the psychosexual stages of development. He totally fabricated and fantasized an entire theory. And of course, that theory is completely wrong. But his observation is completely right. Today we know that in fact, all mental health conditions, if there is one risk factor that has been shown to be true of every single mental health condition, whether it's suicide, whether it's eating disorders, depression, the whole range, it has to do with adverse experiences in the earliest years of life. And of course, this is one of the main reasons why poverty is associated with poor mental health, because when children grow up in poverty, they are far more vulnerable to experience adversities that then affect their developing brains. This is just to show you an infographic from the Center for Disease Control of the US that shows you different kinds of adversities in the form of abuse. Many people think adversities mean sexually abuse. Actually, adversities most commonly are to do with poverty and the neglect that children growing up in poverty experience, household dysfunction, and how that leads to a range of risk behaviors and poor physical and mental health. Actually, adversities in childhood are also one of the biggest risk factors for obesity and a number of other cardiometabolic conditions, and they're all really mediated through a range of different mechanisms. Again, I won't take you through this, but just shows you the importance of integrative science. We have a paper coming out in Nature Medicine next month that really explores the very, very well-described mechanisms and pathways between what happens to us when we are less than 2 or 3 years old and the appearance of a range of conditions, sometimes 30 years later in life, through a range of different, some are well described, some are well studied, others, I would agree, are perhaps not all that well described, but they're hypothesized. For example, the mechanisms through the gut microbiome, I would say, are slightly more speculative. But the ones that are very well described are through epigenetic mechanisms, as well as through mechanisms that are associated through the disruption of the neural architecture. So we've got a risk factor. I call it the tobacco of mental health. We've got a very clearly defined mechanistic pathway involving many different mechanisms. The problem, as Dr. Koshy reminded us, is we don't know which child is actually faltering. This is the single biggest challenge. If you can't measure something, in a scalable way, well, the thing doesn't get acted upon. And at the moment, the only way we can actually measure a child's development is using MRI scans, as we saw in her work, which of course is simply not scalable. Who's going to be doing MRI scans on hundreds of millions of children? It's really a research tool. And so what we really need is a method which allows us to assess the development of a child's brain in that child's own home by a parent, ideally, or a frontline worker. And that method must lead to metrics that are instantaneous, just like anthropometric metrics. You weigh a child, you know immediately, is this child undernourished? And you can immediately, therefore, say this kid needs to actually get a kind of a further assessment or a evidence-based intervention. I remember very well, this idea came to me when I was sitting in my office in the Public Health Foundation of India. This was maybe about 10 years ago. And there was a colleague of mine who had a little kid, came to the office, and the kid was making a racket. And so, in order to distract the kid, the mom said, just gave the kid her phone. And So I looked at the kid playing with the phone, and I said, do you think that's a good idea? And she said, you know what? It's the one thing that, you know, he'll get so occupied with the phone playing a game that he will let me get on with my work. So I said, let me have a look at this game. The kid was playing a game of popping the balloon. And if you have little kids, you remember, there are lots of little games that kids play with on devices. And it struck me, and I said, this is interesting, because what this kid is doing is exercising a whole range of neurocognitive faculties apart from fine motor skills. Is it possible that a cleverly designed game that has been specifically designed to assess a range of neurocognitive functions could actually serve as a proxy to be able to identify what the brain is actually capable of doing? Thus began something that was completely, is hard to tell where this was going to go. I also remember we had a Delhi University student who was acting as an intern. She was in fact a game designer. Can you imagine my luck? And I said, listen, why don't you go ahead and do this, and let's see if we can develop a prototype of a game that can then generate back-end metrics that we can analyze and see whether or not this helps us understand the development of the child. Thus began a journey that is very exciting, and I'll tell you why in a moment. It's very exciting. That began, like I said, with a colleague's little kid. And over the last 10 odd years, we have now developed a platform that you can see being tested here, and I'll probably just see if this video works. It may or may not work. Yeah, it does work. Well, it doesn't work, but anyway, you can see this is one of our frontline workers with this kid. Let's see, maybe it'll work. Anyway, what this game, it's a sequence of games, really testing 14 different brief games that are all wrapped into one narrative. So the child can actually engage with the game, and it's an interesting thing working with this whole work involved working not just with engineers but also with game designers, who are really good, by the way. Game designers earn a lot of money, and they did this completely as part of a kind of a pro bono CSR kind of thing. But they know how to hook kids. They really know how to hook kids. And so what they did was they worked with us to design a game that would really engage the child. We also had a very interesting collaboration with neuroscientists from the Sapiens lab who were interested to do EEGs on these kids. And so what we said was, let's make a game that actually involved an astronaut. The primary character in the game is a kid who is an astronaut, and the astronaut obviously wears a helmet. And the reason we did that is because the EEG was going to be collected on a little skull cap that had electrodes embedded in them. And the entire exercise was conducted, as you can see, in rural homes in Haryana. There was no assessor agreement, there was no Wi-Fi needed. All of this was for the scale of scalability, no written instructions, and of course the software is completely open source. Oh, it is working now. You can probably see the child playing with the game now. The theoretical framework, as I mentioned earlier, again, we eschewed the psychiatric diagnostic system altogether, but aligned ourselves with a more fundamental neuroscience framework that the NIMH under Tom Insel had developed, which really considers psychopathology in the context of major domains of human neurobehavioral functioning. So these were dimensions of neurocognitive function. Where are we today? Well, we have now demonstrated the validity of the scores. By the way, that's another kind of collaboration. We worked with data scientists, because you can imagine the data that is generated from these games is mammoth. And we use both data-driven approaches as well as theory-driven approaches to develop the algorithms that can be used to assess the game results. But the good news is that we have begun to demonstrate that these data are actually very valid. The most important validation we did was to actually examine whether or not the prediction of adversities was as the epidemiological evidence showed. And so what you can see here on this validation is that as a child has a greater number of adversities, the score that was generated by the algorithm showed what we should have expected, a decline exactly as you see if you were doing a more comprehensive, detailed, expert assessment of the child's brain development. I'm going to end by just telling you about where we are currently with this very blue sky program of research. A few years ago, the UK Medical Research Council gave us a very large grant led by Bhishma Chakrabarti with the University of Reading. What we've done is we've joined hands now with a number of other technologies. That includes eye tracking that has also been re-engineered. So we work very closely with engineers to put all of this now, all of these different technologies on the same tablet. So you can see eye tracking here, which is used to assess social communication. This is another very exciting new innovation with the same tablet. We're working with engineers at IIT Mumbai, where we're also incorporating into the same platform video assessments of a parent interacting with their child and then using visual computing methods to derive metrics of, for example, the engagement the child has with the parent. And all of this is on one tablet, assessed in a single sitting by a frontline worker. And what we're then doing is evaluating the ability of this comprehensive set of information to really be able to assess the shape and the function of a child's brain. We're also delighted that Giridhar Babu got one of the Team Science grants from India Alliance, which is examining a range of different determinants of early life brain development, and the DEEP tool is in fact the outcome tool. This is, I believe there's going to be a poster on this that Giri is going to be presenting tomorrow. So for those of you who are interested to know about the practical application of the DEEP tool in an ongoing study, please go and join Giri's poster. What's my long-term vision with my team in Sangat? What we really want to do, our long-term vision is to re-engineer the game now onto mobile phones. Right now it's on a tablet, so that any parent can actually download the game onto their mobile phones. And that we want to generate as many observations, hopefully millions over time, so that we can ultimately create normative scores, just like you have for growth and weight, so that actually one day, when you have sufficiently good data to generate those normative scores, you can actually plot a child on a centile score and say, this child is on the 5th or 10th or 15th centile for brain development when normed against other children in his or her community. And then ultimately, to be able to provide interventions that are evidence-based according to a child's need. Because of course, what's the point of doing all this if there wasn't an intervention? And there is. And those are early child parenting interventions. They are the most evidence-based interventions for promoting nurturing care. Again, Dr. Koshi mentioned this earlier. And I wanted to show you this because it's happening right in our backyard here in Telangana. These are interventions that the government of Telangana is scaling up in partnership with Sangat and UNICEF. These are interventions that are very rich evidence, hundreds of randomized controlled trials. They really encourage a parent to incorporate nurturing practices in basically responsive, stimulating parenting. And what Sangat has been doing with UNICEF is developing the video content to teach parents to actually engage their child in this nurturing way, and then uses groups to deliver the intervention. And let's hope this video works because they're really lovely videos. So the first video shows you just one of the hundreds of sample videos that are used for the training. Let's see if this works. Yeah.
రండి మన పిల్లల జీవితాల్లో అత్యుత్తమమైన ప్రారంభాన్ని ఇవ్వడానికి చేతులు కలుపుదాం. పసిపిల్లలు ఏది నేర్చుకోవాలి అన్నా వారి కళ్ళలోకి తరచుగా చూడటం, ముట్టుకోవడం, నవ్వడం, మాట్లాడడం వంటివి చేస్తూ ఉండాలి. వారు మిమ్మల్ని గుర్తుపట్టి మీకు ప్రతిస్పందిస్తూ ఉంటారు. అలాగే మెల్లగా చుట్టూ ఉన్నవారిని కూడా గుర్తుపడతారు. వాళ్ళు ఎదుగుతున్నప్పుడు వారు శబ్దాలను గుర్తించి వారు సొంతంగా శబ్దాలను చేస్తూ ఉంటారు. ఇవన్నీ మీరు వింటూ అలాంటి శబ్దాలను మళ్లీ చెయ్యడం ద్వారా తల్లి బిడ్డల మధ్య సంభాషణ మొదలవుతుంది. అందుకే
And here is a quick video showing you the parents in a group.
మంచిగా ఉన్న గుణాలను మాత్రం శుభ్రంగా రోజు కడిగి వాళ్ళకు ఆడుకోవడానికి సంరక్షణకు పిల్లలు కలిసి అంటే ఎప్పుడు వాళ్ళతో విడిగా ఉంచొద్దు, వాళ్ళతో పాటు వాళ్ళ.
So I want to finish by just a summary. It's my last slide. Second last slide. So the key principles that I've taken away from this 20-year journey of trying to approach mental health in a very different way. First of all, if the orthodox approach doesn't work, chuck it out of the window. Be brave, be bold, but explore your field through approaches that you believe intuitively to be the right one, even if the orthodoxy suggests it's not. In my work, I've reframed the phenotype. I haven't used a psychiatric diagnosis in my work for 20 years. I instead use people's own descriptions of what's impairing their daily life and combine that with social functioning. A life course approach. What you see when you're 40 years old may have begun when you were 4 years old. Be aware that the health conditions that you see in adulthood, many of them actually have their origins much earlier in life, and there are very good developmental science that explains why that is the case. Integrate different approaches. I'm sure you've got good examples from what I've described. Engineers have a lot to teach us. Computational scientists, cognitive scientists, clinical scientists, epidemiologists, all of us work together. Each of us has something to contribute to this particular question that I deal with. Use technologies not in an end, not just because they're nice to use technologies, but because they catalyze, enable, or facilitate your work. And of course, if those of you working at the translational end, I would recommend always think about intersectorality, because ultimately someone's going to have to use the knowledge you generate in the real world. We've written a little bit about this in Nature Mental Health earlier this year that really actually describes this entire pathway. As I say in this paper, as we titled this, From Neural Circuits to Communities. Actually, the original title was From Neural Circuits to Communities Bypassing the Clinic. Because really it seemed to us that the clinical model wasn't really particularly productive or helpful when it came to mental health. It has worked very well for other branches of medicine, by the way, and there's a good reason why it doesn't work for mental health just as well. But there are very powerful arguments to actually move from fundamental neuroscience all the way through to community health. And this is my last slide. So, friends, just to conclude, business as usual will not succeed in science to reduce the global burden of mental illness. I think we can all agree that I personally in my career have never seen as much interest in mental health as in the last 3 years. And of course, the pandemic has driven much of that political and public interest in mental health, but I think so has climate change. And so it seems to me for those of us who are interested in this particular topic, now is the time to act. And I strongly believe, and I would say that most of the world's leading scientists working in this field would agree with me that we really do need to look outside narrow biomedical, by biomedical I mean narrow clinical models, and look at all the other disciplines that I have alluded to today if we're going to understand what shapes our mental health and therefore how we can prevent and care for mental health conditions. So thank you very much.
The poorer sections, and is also more common in high-income countries. I mean,
Yeah,
isn't that a paradox?
It's called the ecological paradox, absolutely, and that's a terrific question. It's one of the ones that one has to struggle with, right? Why is it, for example, that, just so I can elaborate, at the individual level, epidemiology shows that at the individual level, the risk for depression is greater in poorer individuals, but at the ecological level, the prevalence of depression is higher in wealthier countries. And this points, of course, very importantly to mechanisms that we haven't fully enunciated, which is to do with social capital. That in fact there are also protective factors. Disease is not simply the result of a risk factor. And earlier we heard the word resilience. There are also protective factors that protect people who are exposed to the risk factor from actually developing a health condition. And I think in the mental health field, perhaps this is one of the most important areas, which is that there are clearly resilience factors that we haven't studied because they lie outside the biomedical paradigm. And I'll give you a really great example where again, from the US. I teach a whole course on the fundamentals of mental health that really incorporate all of these fundamental science understandings. And I bring together many different science perspectives. And one of the classes is on race and mental health. Now, all of you will probably know that in the US, there's been a very, very horrible 400-year history of structural violence against black people. And so you would expect, right? Black people are poorer, they are more violated, etc. You can imagine every risk factor for depression is experienced by black people 10 times more than anyone else in that country. So you think black people should have much higher rates of depression than white people. No, it turns out that's not true. It turns out that black people have lower rates of depression than white people. And so it's it's the same kind of, strange kind of epidemiological finding. Why is that the case? So I have a prominent black African-American colleague who's written a lot about this. And he says it's the church. The church for 400 years has acted as a place of refuge that has allowed black people, in spite of all the violence they faced, to find a place where they could stand together in solidarity. And it created, inadvertently over 400 years, a completely different social capital to allow people to, in fact, thrive, even though, epidemiologically speaking, they shouldn't have thrived. So I do think, Gagandeep, there are many more complex interacting processes in complex conditions, and we should never look at this in a linear way, but really examine the interaction between factors.
I totally get, I'm a neuroscientist myself, so I totally get that the early childhood experience or trauma could lead to mental sort of health problems, but I'm having trouble seeing the causal chain between specific mental health problems, like say, whether you take, of course, autism is a spectrum, but if you take something more specific, like say Alzheimer's or Parkinson's or other kinds of very specific, schizophrenia is another example, where can you really trace those back to early childhood sort of incidents or...
So there's a number of different pathways, you're right, because what I showed you was simply the mechanisms through which early childhood experiences affect cognitive development. You're asking a really important question. How does cognitive development then connect with the rather pleiotropic finding that in fact it seems to predict almost every other mental health problem? So there are clearly different pathways for different mental health problems. You gave the example of dementia. The most plausible example is cognitive reserve. The idea is that when you have adequate brain development in early life, you simply build a greater density of neural networks. And therefore, when there is the aging process, plus there could be some other risk factors like vascular risk factors, that essentially you basically have more of a reserve in your brain that protects you. So it's still speculative and hypothesized, but that is a plausible mechanism. If you consider other mental health problems like depression, the main thing is to do with cognitive capability to deal with the hardships of everyday life. So that's one mechanism, and the other mechanism is education. Let me explain why. It's pretty intuitive that if your brain is cognitively better developed, you'll do better in school, right? I mean, that's the main outcome of cognitive development is learning outcomes. And so if you can learn better, you do better in school. If you do better in school, you have a better job. And if you have a better job, you're socioeconomically better off. So you can see the economic pathway there too. So there are many different pathways. And that is why early child development is, in my mind, one of the most, in fact, it is currently the only real individual target that we have for prevention in mental health. There are many other social targets, but at the individual level, it's the only one that's been replicated. So thank you very much.